We're bypassing the basics today. We're going straight into the high-yield, next-best-step logic you need to master mechanisms, treatment branches, and specific exam traps for neuromuscular disorders.
We'll be hitting weakness localization, inflammatory and endocrine myopathies, medication-induced myopathy and rhabdomyolysis, myasthenia gravis, acute myasthenic crisis management, and finally, Lambert-Eaton syndrome.
Section 1. Localizing weakness and mimics. True weakness versus pain and fatigue.
Before we can even begin to localize a lesion, we have to figure out if the patient actually has true weakness or if it's just pain-limited motion, stiffness, or fatigue. If it's true weakness, we map the anatomic defect. Upper motor neuron lesions give you spasticity and hyperreflexia. Anterior horn cell disease? That yields motor weakness without the sensory loss. Peripheral nerve damage adds sensory loss to that distal weakness. If we're looking at the neuromuscular junction, expect fluctuating, fatigable weakness. And muscle fiber diseases cause symmetric proximal weakness with totally normal sensation, often with an elevated CK.
Let's talk about symmetric proximal weakness. The patient who suddenly can't rise from a chair or comb their hair. We absolutely have to exclude common mimics here. Take polymyalgia rheumatoida. It hits patients over 50 with shoulder, hip, and neck stiffness. You'll see an elevated ESR or CRP, but the CK is completely normal. It responds incredibly fast to low-dose prednisone, and you have to screen for giant cell arteritis. Now compare that to fibromyalgia. That's chronic, widespread pain, fatigue, poor sleep, tender points, but their labs? Completely normal.
Section 2. Inflammatory and endocrine myopathies, polymyositis, dermatomyositis, and endocrine causes.
So, diving into true myopathies, polymyositis and dermatomyositis both present with proximal symmetric weakness and elevated CK, LDLase, AST, ALT, and LDH. But dermatomyositis is a whole different beast. It adds Gottron papules, that classic heliotrope rash, maybe a photosensitive rash or a Schall sign. You need to watch out for massive complications like dysphagia with aspiration risk, myocarditis, and interstitial lung disease. Diagnosis involves autoantibodies like anti-Jo1 or anti-My2, and sometimes EMG, MRI, or a muscle biopsy. But here is the massive exam trap. Dermatomyositis requires an aggressive screen for occult malignancies, like ovarian, lung, or colorectal cancers. We treat these with high-dose glucocorticoids and steroid-sparing immunosuppressants.
Now, you have to be able to contrast these two endocrine myopathies. Glucocorticoid myopathy gives you painless proximal weakness, usually in the legs, with muscle atrophy and a completely normal CK. On the flip side, hypothyroid myopathy presents with pain, myoedema, delayed deep tendon reflex relaxation, an elevated CK, and of course, abnormal thyroid tests.
Section 3. Medication myopathy and rhabdomyolysis, drug triggers and acute kidney injury.
Drug triggers for rhabdomyolysis basically fall into three distinct buckets. First, you have direct myotoxicity from things like statins, fibrates, and colchicine. And keep in mind, statins can cause anything from an asymptomatic CK elevation to full-blown rhabdo. The second bucket is vasoconstrictive ischemia, think cocaine and amphetamines. And the third is compression ischemia. This happens from prolonged immobilization due to CNS depressants like alcohol, opioids, or benzos. You can also see this with crush injuries, extreme exertion, or hyperthermia.
Let's look at the pigment nephropathy panel, which confirms skeletal muscle necrosis. The patient rolls in with muscle pain, weakness, and extremely dark urine. The urinalysis is heavily heme positive, but, and this is key, microscopy shows 0 or maybe very few actual red blood cells. You confirm the diagnosis with a CK above 1,000. Since the muscle cells are bursting open, intracellular contents just spill out. You get hyperkalemia, hyperphosphatemia, and an AST greater than ALT. You'll also see hypokalemia because the calcium is rushing in to deposit right into the damaged muscle. Management here is absolutely crucial. Pump them with aggressive IV fluids to prevent acute kidney injury and monitor closely for compartment syndrome.
Section 4. Myasthenia gravis and exacerbations. Postsynaptic fluctuating weakness.
Shifting gears to the neuromuscular junction, myasthenia gravis is a postsynaptic acetylcholine receptor disease. The absolute hallmark here is fluctuating, fatigable weakness that gets worse with use. You're looking for ocular symptoms like ptosis and diplopia, bulbar symptoms like dysphagia, and neck or limb weakness. A really cool bedside trick is the ice pack test. The cold actually inhibits acetylcholine breakdown, so you'll see the ptosis rapidly improve right in front of you. confirm it with acetylcholine receptor antibodies, and immediately order a chest CT to rule out a thymoma. We treat this with acetylcholinesterase inhibitors like pyridostigmine, immunotherapy, and a thymectomy if it's indicated.
You have to know the strict contraindications here. Avoid trigger medications that block neuromuscular transmission at all costs. I'm talking magnesium sulfate, fluoroquinolones like moxifloxacin, and aminoglycosides. Other things like neuromuscular blockers, CNS depressants, beta blockers, calcium channel blockers, opioids, and statins either need to be completely avoided or used with extreme caution.
Section 5. Myasthenic Crisis Acute Management. Respiratory Failure Protocols.
Things can go south fast. A life-threatening myasthenic crisis can be triggered by infection, surgery, pregnancy, an immunosuppression taper, or those offending medications we just talked about. A crisis means worsening generalized or oropharyngeo weakness that is actively causing respiratory insufficiency. Have a very low threshold for respiratory monitoring and intubate immediately if their respiratory status deteriorates. Then, hit them with rapid-acting immunotherapies like IVIG or plasmapheresis, along with corticosteroids. And here is a huge step to remember. Once they are intubated, you must temporarily hold their daily acetylcholinesterase inhibitors, like pyridostigmine. Why? Because it reduces excess airway secretions and minimizes their aspiration risk.
Section 6. Lambert-Eaton myasthenic syndrome, presynaptic calcium channel disease.
To wrap up the neuromuscular junction, you have to contrast myasthenia gravis with Lambert-Eaton syndrome. While MG is postsynaptic and worsens with use, Lambert-Eaton is a presynaptic voltage-gated calcium channel antibody disease. It causes proximal weakness, really prominent autonomic symptoms like dry mouth, and diminished reflexes. But here's the clincher. Those diminished reflexes actually improve with repeated muscle use. This is a paraneoplastic syndrome, which means a workup for small cell lung cancer is absolutely mandatory. For treatment, you target the underlying tumor while using symptomatic therapies to increase presynaptic acetylcholine release.